just sort of sum up. First of all, I think despite our original plan was to have an argument about who should lead perioperative care, I think there's clearly consensus that it needs to be multidisciplinary, and there needs to, judicious use of appropriate preoperative testing and so on is appropriate, but not in everybody. Second thing, talked about a few things that Kellett had advantages that we perhaps can use a little bit of an excuse for why we aren't achieving quite the same results as him, but do remember that important role of the charge nurse. The third thing, I think we broadly agree that perioperative care is running the risk of becoming too complicated, and that we need to continue to revisit Kellett's original paper, which talked about how a nice simple program could receive
something
results.
that's important. We'll work out the things that are important for your particular hospital so you can target those.
And then the last area was we agreed upon a series of sine qua nons, basic things that you've got to have in an ERAS program, whatever you're doing, whether it be orthopaedic, colorectal, sleeve gastrectomy, or whatever area that your liver surgery or whatever it might be. And they include very clear expectations for the family and the patient.
Yeah.
An anaesthetist who, looks after patients carefully and manage the fluids well. Early feeding and mobilisation, keeping tubes out of people, including catheters, because they lead us to probably give too much fluid to people. And then the use of steroids, which I think probably isn't particularly controversial anymore, but it is a bit of a watch this space in terms of the malignancy area.
Yeah. And finally, early nutrition of the patients, getting them eating and drinking and trying getting them to use the oral route for everything wherever possible.
Well, thanks, Nick. Thanks for joining me. And,
my pleasure, Andrew.
Have a good afternoon.